Hey everyone, greetings from Dr. Prepper. Since we discussed coagulation last week, I thought it would be nice this week to bring up part 2 of the same topic and discuss anticoagulation. So let's discuss some clinical concepts around it to help you answer these questions better. Let's go get you that PG seat and let's look into today's discussion. Why I want to bring up this anticoagulation discussion for today is it's a very important part of medical management and surgical management of a lot of diseases. You will use it in clinical scenarios to manage a lot of conditions, as prophylaxis for a lot of conditions, and it plays a role when you're planning surgery for a patient. So all these things are very important to know, and I will try to highlight them to the best of my abilities in this video. So let's look at some of the questions that came from this topic previously. So another question I came across in some previous year's papers were something which is actually very similar to last week's question, which goes as, which of these factors are inhibited by warfarin when used as an anticoagulant? So the answer to this question is again C, which is factor 7. So how did we arrive at this answer? Let's just look into the concepts of anticoagulation, and I'm sure we'll be able to figure this out. So as a follow-up from last year's discussion, what we are going to discuss today is anticoagulation. So what is anticoagulation? Simply put, anticoagulation is the prevention or slowing down of formation of the fibrin clots. So how do we achieve this? We achieve this by using various amount of drugs which inhibit different steps of the coagulation pathway that we talked about, and therefore help in prevention or slowing down of these clot formation. So why do we need anticoagulation? So a lot of indications of anticoagulation. Some common ones which are handy to remember are coronary artery disease post-stenting. If you have had history of deep vein thrombosis, either the first event or recurrent events. If you have pulmonary embolism, unstable angina, atrial fibrillation where you're prone for your heart to throw clots into your bloodstream. If you have any kind of vascular surgery, you've had any endovascular procedures or open bypasses, or if you have a prosthetic heart valve, you need to be on anticoagulation. So these are the common indications we look at. So let's look at some anticoagulant drugs. So the most common anticoagulant that you would have heard about in the past is heparin. So heparin is the one of the most common anticoagulant drugs used in a hospital setting when patients are admitted. Mostly because it's a subcutaneous administration. You can achieve it on an OPD basis also, but obviously that is inconvenient for the patient. So because it is administered subcutaneously, it's usually used in a hospital setting. So how does it act? Like I mentioned previously also, it binds to antithrombin 3. And what does antithrombin 3 do? If you revisit the whole presentation, you will know that it decreases the activity of thrombin and factor 10A. So it affects factor 2A and factor 10A. And therefore heparin, after binding to antithrombin 3, activates it and causes inhibition of this factor 2A and factor 10A. The important thing with heparin is it requires monitoring. It requires regular monitoring of which test. So as we know, factor 2A comes in the common pathway. So does factor 10A. It mostly affects the APTT, which is very important to remember. So it affects the APTT, and therefore regular almost Q6H or every 6 hours to Q8H. Every 8 hours you need to repeat APTTs to check the levels, and you're supposed to titrate the dose of heparin based on those levels. These levels that you find out by regular monitoring of APTT. It's very important to know. One thing you have to know related to heparin is protamine sulfate. So what is this? You would have heard this drug commonly. This is basically an antidote to heparin. It has antagonistic action. So if you have heparin toxicity, if you feel that the APTT has gone way too high, usually we target a level, clinically we target a level of 50 to 80 of APTT. The usual is somewhere less than 30. So 50 to 80 of APTT is targeted, and if you feel like you've crossed, the APTT has gone too high, you can use protamine sulfate as an antidote. So the antidote to heparin is protamine sulfate. Very important to remember. So coming to LMWHs, which stand for low molecular weight heparin. Low molecular weight heparins. So these are basically the heparin molecule has been cleaved artificially and while still retaining their action. So again, their administration is also subcutaneous like heparin, but the difference being they do not require monitoring. You don't need to do serial APTTs. So they usually have a more stable action and a very predictable action. So a usual regime is usually enough. The most common one used is Clexane, the technical term of which is enoxaparin. Clexane, you would have heard, it comes in fixed preloaded syringes of 20, 40, 60 and 80 milligrams. So one important thing that you get asked a lot is the dose of Clexane. So the therapeutic dose of Clexane is 1 mg per kg twice daily. Very easy to remember, 1 mg per kg twice daily. So often some people ask or you get questions asked as in what if someone is 70 kilograms. So obviously his required dose would be 70 mg BD. But as we said, there are preloaded syringes which come only in these values. So how? So what you give is you give 80 in the morning and you give 60 mg in the evening. So you achieve a total dose of 140 mg over a day, which is what you require. So this is important to know. This is the dose of Clexane. Another low molecular weight heparin is dalteparin, which is commonly used. However, nowadays it's not much in practice. Another thing I want you to know is about this drug called Fonda Paranox. So what is this? This is an artificial drug. It's actually a pentasaccharide. So this also is not exactly from the heparin molecule. However, it has the same actions where it inhibits the action of factor 10A and therefore inhibits coagulation. So why I want you to remember Fonda Paranox is heparin causes a side effect called thrombocytopenia. It can cause a fall in your platelets because it has significant anti-platelet action also. So when you have heparin-induced thrombocytopenia, you need to stop the heparin. Fonda Paranox is a drug of choice when you have heparin-induced thrombocytopenia. Induced thrombocytopenia mein drug of choice is Fonda Paranox. So if you say what is the most common use of Fonda Paranox, you must remember that it is a drug of choice for heparin-induced thrombocytopenia. That is very important to remember. So for sake of completion in the administered anticoagulants, there are some direct thrombin inhibitors also, which are lepiridine, which is basically a recombinant molecule of hiruidine. Hiruidine, if you've read, is basically derived from the leech, which was where anticoagulants were actually discovered. So lepiridine is a recombinant molecule of the same. Argatroban is another one of those, which is a direct thrombin inhibitor. They don't need to bind to antithrombin 3. They directly inhibit the molecule of thrombin. And if you remember the coagulation cascade, thrombin is responsible for increasing the action of a lot of factors. So these molecules actually inhibit all those steps and decrease the coagulation cascade moving forward. Both of them are administered as IV infusions, again to be remembered. So they are administered anticoagulants. So now that we've looked at so many of these administered anticoagulants which are used in a hospital setting, now let's look at some oral anticoagulants which can be used on OPD basis very conveniently. So the most common oral anticoagulant that you'll hear about is warfarin. It is very commonly used, especially in low resource settings, because it is a relatively cheap drug. All these new anticoagulants that we'll talk about are relatively expensive. Warfarin is still one of the cheapest options available when you want to give long-term anticoagulation, like for deep vein thrombosis or pulmonary embolism or for heart valves. Warfarin still remains the cheapest option for long-term anticoagulation. So how does warfarin act? First of all, it's administered orally, therefore patients can be discharged on warfarin. It is a vitamin K antagonist. So as you remember, the factors that vitamin K dependent were 2, 7, 9 and 10. So this is where you answer our question also. If you're putting something on warfarin, it will inhibit all the vitamin K antagonists, and therefore the answer to that question was factor 7. So how does this do that? You get questions on that also. So what warfarin does, it inhibits this vitamin K epoxide reductase. That is this enzyme that is inhibited by warfarin. So it inhibits this. The gamma glutamyl residues of vitamin K cannot be oxidized, and therefore the clotting factors cannot be activated. So it's very important. It inhibits, you need to know the name of this enzyme. The residues are gamma glutamyl residues. The name of this enzyme, you can get questions from any of these. So another thing about warfarin is it requires regular monitoring. It affects the PT-INR, which is checked on regular basis, and based on the dose of warfarin is titrated. That is the only thing that makes warfarin very cumbersome, because unless you have achieved a dose where the patient's INR is staying stable, you need to keep reviewing them in OPD and titrating the warfarin dose. So it's very important. PT stands for prothrombin, as you know. INR stands for international normalized ratio. And few of the common ranges that you need to know is, if you are giving warfarin for a DVT, you need to stay within an INR of 2 to 3. If you are giving it for prosthetic heart valves, you need to stay between an INR of 2.5 to 3.5. So different disciplines have their own ranges of INR that you try to achieve by keeping them on warfarin. So once their INR is staying specifically within this range, then you can continue the same dose, but till then you have to continue reviewing them and looking at their values of INR and titrating to those of warfarin. So another form of warfarin that is commonly used is acetrom. Acetrom is basically, the drug is nicumalone. It's another vitamin K antagonist only, so it acts the same way like we spoke about previously. However, it acts more rapidly. That is the only thing you need to remember. Acetrom also needs regular monitoring of PT-INR. However, for individuals in which warfarin is not producing a desired effect, you can switch them to acetrom and give them a trial of acetrom or nicumalone to see if their INR is increasing, and if it is, then you can keep them on acetrom for the same. So again, because these require regular monitoring, people wanted to move towards other drugs that they wanted to give. So let's look at some of these other oral anticoagulants that are given these days. So while I was going through these questions, I also realized that you get a lot of questions from this new drug group called NOAC. So which of these falls under the drug group NOAC? Warfarin, acetrom, aspirin, dabigatran. So the correct answer to this question is actually option D, which is dabigatran. Now, how did we arrive at this answer? How do you know what are NOACs? Let's discuss about them a little bit. So what are NOACs? NOACs stand for newer oral anticoagulants. There are a lot of other names also, like new onset or new age anticoagulants. So they all stand for the same group of drugs. So what are these drugs? Again, remember, they are oral drugs that can be given, so they are very handy. The first one is dabigatran, like the answer to a question. It's a direct thrombin inhibitor. So like you remember argatroban and lepirudin, but those were IV infusion. This is an oral direct thrombin inhibitor. It is usually in a form of dabigatran etexylate is what will be called. So you might be asked that this is the inactive form of which drug. So as it is in the name, it's dabigatran. So this is the form in which it is administered. It causes direct inhibition of thrombin. The other drugs that you need to know in the NOAC group is Apixaban and rivaroxaban. These are factor Xa inhibitors. As you know, factor Xa is a junctional step of the common pathway. Both the intrinsic and extrinsic pathways lead to this. So if you inhibit factor Xa, you are inhibiting both the intrinsic and the extrinsic pathway of anticoagulation. Very important to know. Therefore, Apixaban and rivaroxaban. So how do you remember this? Remember, the names of Apixaban and rivaroxaban have this X in them, and this X is basically factor Xa inhibitors. So remember that if then X is there, they are factor Xa inhibitors. The X is not there, the dabigatran D stands for a direct thrombin inhibitor. Very easy to remember. Again, very important to know, being oral anticoagulants, but unlike warfarin and acetrom, they do not require monitoring. There are fixed doses that you can give them in, and once you are administering those doses, you do not need to review them in OPD on regular basis for to keep an eye on INR or any such values. You can start the dose and keep them on the same dose for whatever 3 or 6 months period that you require. So that's everything you need to know about NOACs, or new oral anticoagulants. So for sake of completion, you can always say, but what about primary hemostasis? What about the platelets? What about the platelet plug formation? So there are some anti-platelet drug also that we can discuss. So the first category comes as platelet aggregation inhibitors, which has 2 categories: cyclooxygenase inhibitors and thienopyridines. So these are the 2 common drugs which are very commonly given: aspirin and clopidogrel. Aspirin basically inhibits cyclooxygenase 1 as an enzyme, which causes inhibition of formation of thromboxane A2. That's an arachidonic acid product. So you have to remember which enzyme it inhibits. It's usually low dose aspirin that causes this action. In low dose aspirin, it selectively inhibits thromboxane A2 and does not inhibit the other prostaglandin action or the prostaglandin's production that COX-1 causes. So remember, COX-1 cyclooxygenase 1 enzyme is what it inhibits, causes decreased production of thromboxane A2, which causes decreased platelet action. Thienopyridines are clopidogrel, prasugrel, ticagrel, or these are all more potent anti-platelet drugs. There are also glycoprotein inhibitors, which is apixaban, which is the active form of a monoclonal antibody. The monoclonal antibody, as you can see by the MAB at the end, and these inhibit GP2B3A receptors. So you can get a question from this saying these glycoprotein inhibitors or apixaban inhibits which receptor. So these receptors, as I had discussed in the previous presentation also, these receptors are very important for formation of the platelet plug, the glycoprotein 2B3A receptors. So this apixaban and another drug called tirafenib, they inhibit these receptors. And there are also phosphodiesterase 3 inhibitors called cilostazol, which can also be used. The drugs from this that can be asked mostly are aspirin, clopidogrel, and occasionally you will get a question from apixaban. So you must remember these points that you can get questions on. So some information that is clinically very relevant to you is a lot of surgeons don't like operating when the patient is an anticoagulant because obviously the risk of bleeding is high and that will interrupt with the operative field also. So how much time before surgery do you need to discontinue these anticoagulants? Very important to remember. So we'll only discuss the common ones that we use. So coming to the subcutaneous administration ones, there is heparin and there is clexane that is commonly used. So when a patient on oral anticoagulation long term is admitted, you usually start them on heparin or clexane. One thing I want you to remember about clexane is you can only give it to patients whose creatinine value is normal. Since it's a drug which undergoes mostly renal clearance, someone's creatinine is abnormal or increased, you cannot give them clexane, you have to give them heparin. For people with normal creatinine, you have an option between heparin and clexane. Both of them, the dose on the day of surgery needs to be stopped. The dose on the day of surgery should not be given till the previous day, till 12 hours before the surgery, you can give the dose of heparin or clexane that is due. But the dose on the day of surgery till 12 hours prior should not be given. Usually patients when admitted, they are kept on heparin or clexane only, and that's why this is the regime that is usually followed. You can restart it 12 hours after the surgery, but this is mostly left to the surgeon's preference. Okay, coming to the oral options, you have aspirin, you have clopidogrel, all those thienopyridines that we talked about, and you have dabigatran and apixaban, the NOACs. So aspirin, a lot of individuals do not mind operating on aspirin, so it can be continued. Again, it's a surgeon preference thing, but can be continued. Clopidogrel needs to be stopped 5 to 7 days before surgery. Some people say 5, some people say a full week, but this is the one that has the longest period of time to reverse. So 5 to 7 days before surgery, you need to discontinue clopidogrel. You can start them on clexane or heparin and while they are admitted, but they need to stop clopidogrel. If a patient is on clopidogrel, most anesthesia teams will not accept the patient for surgery. It's very important to remember that clopidogrel needs to be stopped 5 to 7 days prior to surgery. Coming to the NOACs, NOACs take 48 hours for their action to wear out. So 2 days before the surgery, the NOACs need to be stopped. And you can, as I mentioned earlier, you can put them back on heparin or clexane for that duration. But 2 days before the surgery, you need to stop the NOACs. So these are some important facts to know about which anticoagulant needs to be stopped when, if the patient is planned for surgery. And I hope that was helpful for you guys. So that brings us to the end of this 2-week saga around coagulation and anticoagulation. Hope you like and share this video. Subscribe to the channel if you want to continue listening to discussions like this. And let me know in the comment section if there are any specific topics you would like me to cover. So keep up the good work, all the best for your NEET, and see you next week.